If we want to have a discussion about QALYs and applications of QALYs and different assumptions made in these applications, we need, in order to have a constructive discussion, be clear about what we talk about. So how are QALYs defined? How do you measure QALYs? How are the results used? Emelie Heintz will help us to clarify these important issues. So Emelie, the floor is yours.
Well, sorry. Well, thank you very much. I'm very happy to be here and honored to have been asked to give this introduction to quality-adjusted life years and why health economists use them in health economic evaluations. I work as a health economist at the Swedish Agency for Health Technology Assessment and Assessment of Social Services, where I use health economic evaluations in my daily work. I'm also doing a postdoc part-time right now, where I'm also working with quality-adjusted life years and the methodological issues related to how to measure health-related quality of life for use to calculate quality-adjusted life years. So I hope I'll be able to give you the basics so we can continue the discussion later on with a common ground to stand on, because it's quality-adjusted life years are a little bit of a complicated concept, but I hope you'll understand after this session. But I think there will be room for some questions afterwards. So if there is anything you feel a bit uncertain about or have questions about, please raise those questions afterwards. To begin with, I would just like to give you a little bit of a context to why quality-adjusted life years have been developed, or why this measure has been developed. And it has to do with what Göran mentioned before, that the resources of the healthcare sector are limited. This is one of the main assumptions or the main realities that we deal with. And that the needs of the patients in principle are endless, which means that we have a conflict there. And since all resources within the healthcare sector have an alternative use, we need to decide how to use these resources, and there is a need to prioritize. And this prioritization can be done explicitly or implicitly, as Göran so good demonstrated before. And I think this is using quality-adjusted life years has been a way of trying to do this explicitly, even though it might maybe be understood as implicitly in one way, as Göran showed. In Sweden, to guide prioritization, we have the ethical platform for priority setting in Swedish healthcare, where the cost-effectiveness principle is one of the principles, but it's only one of them. And I think that's something that all health economists also agree with, that it's not only one input to healthcare decision-making, it's one input. And I think this is very important to state. The cost-effectiveness principle says that we should strive for a reasonable relationship between costs and effects. And here, effects are defined as measured in terms of improved health and quality of life. I want you to remember this, that it is about a reasonable relationship between costs and effects, because I will come back to that. So to decide if this relationship is reasonable or not, there are different methods. Some of the most common ones are these types of health economic evaluations. We have the cost minimization analysis, which is analysis that we use when the effect is equal between two interventions. So if we have treatment A and treatment B and there is no difference in effect or outcome, we just look at the costs. And the intervention that minimizes the cost is the most cost effective. But then we also have cost effectiveness analysis and cost utility analysis, where we put the costs in relation to an outcome. And the outcome can be quality adjusted life years. but it can also be other types of outcomes. When it is cost per quality-adjusted life years, we usually refer to the analysis as a cost-utility analysis. In this type of analysis, we need a threshold for the willingness to pay per outcome. And it's there where we need some kind of price or a willingness to pay for the outcome. So we need some kind of threshold. And I will come back to that later. There's also another type of analysis, which is called cost-benefit analysis, where we look at the net benefit, where we also value the benefit in monetary values. However, or I would say this type of analysis is often used, for example, in the transport sector, where you have a value of a statistical life. I don't remember exactly what it is right now, but it's somewhere, I think, between or over 20 million Swedish crowns per life. However, there has been there are methodological and ethical problems related to estimating the value of the monetary value of health benefits. And that's why the research has moved on to quality-adjusted life years. And one example of an ethical problem is, for example, that if you're about to state your willingness to pay for a health outcome, it might be that people that have a larger income can pay more for a health outcome, and that then diseases that are more common among people that are more wealthy also have a larger value or higher value. Or it doesn't have a high value, but it can be estimated as having a higher value because they have a larger budget. And this is something that we want to avoid, and that's why the quality-adjusted life years concept was developed. So in a cost-effectiveness analysis, we always compare two treatments, or a treatment with just continuing doing what has been done before, which could also be doing nothing if that was the standard at the moment. But there's always two alternatives that are compared. And we look at the costs and the outcomes of each alternative, and then we compare these two, so we get a cost per outcome. And so what is this outcome then? I have already mentioned quality-adjusted life years, and I will come back to that. But there are different alternatives, and one alternative is, or are the clinical outcome measures that are often used. And one such clinical outcome measure could, for example, be fractures, the number of fractures after a specific intervention. It can also be symptom-free days, or it can be events such as heart failure or stroke, or all these kinds of clinical outcome measures. Then we do the same as I showed before. We compare the costs, and we compare the numbers of fractures in this example, and we calculate the cost per fracture avoided. Can you see any problems with this kind of calculation? Or is there some information that are missing? I want you to think about it. Do you want to say something, Christian? Yeah, if you can do it quickly, I would be very happy for you to do it.
One of the objectives with having a quality-adjusted life here as an outcome measure is in principle, you may not be able to, but the purpose is to be able to compare interventions between therapeutic areas. But I mean, in this case, using the physical measures, you will not be able to do that. But I mean, in practice, the cost-effectiveness ratios measured in QALYs are more or less, I think, used within therapeutical areas. You don't use it for sort of an exchange rate in order to trade utility between different types of patients. That was just mine.
No, exactly. As Christian said, we can't use this outcome measure to compare between different clinical areas. That's one of the problems that have been written about. But there's also another one, which is that we don't really know what it means to the patients. So that you don't get a fracture. What does that mean for your life, for your quality of life, and for your daily activities, for example? So one of the things would be that we would like to know more about how are the patients affected by this, to be able to say what we are willing to pay for it. Another outcome measure that can be used are life years. It is often used in many clinical studies. And we do the same thing there. We can calculate the difference in costs and the difference in life years and calculate a cost per life year gained. But here's also one more thing that many people would argue that you would like to know if you're going to say what it should cost. And it is how those life years are. Are they good life years or bad life years? How is your quality of life during those life years? Are we willing to pay more for life years with a high quality of life than if those life years have a very, very low quality of life? And this is where the discussion about quality-adjusted life years have started. We want to know both how it affects survival, but also how it affects the quality of life of the patients. And I would like to say here that when I talk about this, I always talk on a group level and not on an individual level. So I'm not saying that this is something that is used in the individual meeting with the patient, between the doctor and the patient, but always on a group level. So if we would put numbers on this, it could look like this. That if we only use life years here, it could be that one treatment costs about 2.5 million Swedish crowns, and the other treatment costs about 2 million crowns. You gain 5 life years in one of them. This is a life-prolonging treatment, and 4.5 with the other one. This means that we would have a cost of 500,000 more with treatment A, and we would gain half a year more if using this treatment instead of another. And then the cost per life year gained would be about 1 million Swedish crowns. And then I just want you to think about it briefly here, that would this be cost effective? And would you like to know more about how those life years are? So what kind of outcome measure would we like to have to decide if the relationship between costs and outcomes is reasonable? Well, it has been suggested that it should be a measure that reflects changes in survival and health-related quality of life, as I said before. That it should enable comparisons across clinical areas, as Christian was talking about down here. That it should both reflect benefits and opportunity costs, and that it should be able to capture changes in different dimensions of health-related quality of life, but also be sensitive to changes in health-related quality of life. So we actually capture differences in health-related quality of life that the treatment can cause. So, what is the quality-adjusted life year? Well, the basic idea is that it is a composite measure of effect on health-related quality of life and survival, and it is often referred to a utility, which is something that I think is important to remember, because I'm coming back to that later. And in this QALY concept, survival is measured in life years gained, as in the example before, and health-related quality of life is measured on a scale between 0 and 1. You can see the scale here. This is not completely true, because we also have health states that can be considered worse than dead. And then you are actually below the 0 here. And this could, for example, be health states that cause a lot of pain, where patients actually consider them to be worse than dead. And then you can, when you look at the effect of a treatment, you can actually be below the 0. So you can also get an effect from minus 0.2 to minus 0.1. And that is also something that is very important to remember. And using this kind of scale for health-related quality of life enables this kind of comparisons that I was talking about before between different clinical areas, and between different diseases, between different age groups, different severity of diseases, and social groups. When you calculate the QALYs, you multiply the life years that you are in a specific health state with the health-related quality of life of that health state. The health-related quality of life can, of course, change during a lifetime, so it's you multiply the years in a specific health state with the value of that health state, and then you add the other years in other health states. And this means that if you talk about one QALY, it can mean different things. It can mean 1 year with full health, but it can also mean 2 years with 50% health. It can also mean 4 years with 25% health, or 4 persons that get an improvement of that improve their health-related quality of life with 25% for 1 year. So when we move on this scale for the health state value or the health-related quality of life, a difference between 0.1 and 0.2 is regarded the same as between 0.8 and 0.9. It also means that if you have an improvement from 0.1 to 0.4, it's the same as an improvement of 3 persons getting an improvement from 0.8 to 0.9. So this is one of the simplified assumptions in the model. But it's also one of the criteria for the health state value to be on a cardinal scale. So we can use them in this kind of calculations. And to show you an example here, I want you to think, this is just an example and it's just fictive, so it's not based on a clinical study. It's just for you to understand how it works when we calculate the quality-adjusted life years. So don't take it too seriously, but we will look at 2 different kind of treatments here. If a patient is living with full health, they will be on the 1 here all the time. You see you have the scale with health-related quality of life vertically, and then you have the scale with life years horizontally. And if you're in full health, you'll be on the 1 the whole time. But in this case, I want you to think about that we have a treatment, a dialysis treatment for someone with kidney problems, and the quality of life of that person might look like this. As I said, it's just a fictive example, but we can imagine that the quality of life is kind of stable in the beginning, but then it drastically decreases. If we instead imagine that we can offer a kidney transplant in this case, it might instead look like this. That in the beginning, after the kidney transplant, the quality of life decreases. But with time, the kidney transplant was successful in this case, and it increases and actually gets higher than if the patients would have stayed with dialysis. If we would only have looked at life years here, compare these 2 kind of treatments on survival, I want you to just think about which treatment you would prefer, if the only thing you would know was how long you would live after these treatments. Well, I think many of you would say that there would be no difference because the patients die at the same point of time. However, if you look at the health-related quality of life, you can see that area B here, which is what you lose with the kidney transplant, is smaller than the area B, which is what you gain with the kidney transplant, which might make you instead think that the kidney transplant actually is a better choice. And this is how we calculate quality-adjusted life years. We look at these areas. And if area B is larger than area B in this case, then the kidney transplant would generate more QALYs. There are many different methods to estimate the value, or the health-related quality of life value that we use in this kind of calculations. You have the direct methods and the indirect methods. I think the ones that you usually hear about are the indirect methods, such as the EQ5D and the SF6D, which is based on the SF36. These are questionnaires that are used, that the patients fill in or complete, but they are always valued with one of the direct methods or scored with one of the direct methods if they are used in this kind of calculations. So there has always been some kind of valuation involved, either by people that have experienced the health state or by the general public who have had health states described to them. So this is very important to remember. And I'm just going to show you very briefly how these methods can look like. And we'll start with the standard gamble. In this case, the patient or a person from the general public is presented with 2 alternatives. You have one alternative where you will live with full health for 10 years from now, or you can also die immediately. And in this case, you present a probability of getting full health immediately and live with that from 10 years from now. So we could say that there's a gamble between, or we can say that it is a treatment where you have a 50% probability of living with full health 10 years from now, but you also have a 50% probability of dying immediately. And then you compare that with having for certain being able to live in your current health state for 10 years, or in a health state that is described to the person that answers this, and you ask the person which of these alternatives you would choose. And when you vary the probability of living with full health for 10 years with and present this repeatedly and find the indifferent point where the respondent is indifferent between the gamble and living 10 years in the health state that is being evaluated, you find that the probability P, and that is the health state value. So if you are willing to accept a larger risk of dying immediately, it also means that your health state is worse. Another method that is often used is the time trade-off method, and in this case we use time instead of probabilities to estimate the value. So you would ask the persons to imagine that they have maybe 10 years left to live, and that they can choose to live these 10 years in the current health state, or that you can choose to live for a shorter period of time in full health. And then, would you prefer to live 10 years, in this case, with your current health state, or 5 years in full health? And once again, when you repeat this question and find the years in full health that makes the respondent indifferent between these two alternatives, you also find the health state value or the health-related quality of life. And what you can see that these two methods have in common is that the respondent is asked to trade something to get better health. And that is because if you're going to see that say that something is of value to you, you have to be willing to trade off something to show that it really is of value. So that is the basic idea behind these two kind of questions. I mentioned before that the QALYs can be regarded as utilities or cardinal utilities. And if you look back into welfare economics, which can be regarded as the theoretical background to the quality-adjusted life years, it assumes that the QALYs should be cardinal utilities. And that something is a cardinal utility means that it should reflect the intensity of people's preferences, and that an individual choosing between two treatment alternatives should prefer the alternative that produces the most QALYs. So if a treatment produces more QALYs than another, it also means that people should prefer the one with the most QALYs. But for that to be true, there are certain criteria that needs to be fulfilled. And one of them is mutual utility independence, which means that the utility of life years and the utility of quality of life should be mutually independent of each other. So that the utility of quality of life should not be related to the number of life years you are in the health state. Another one is that if you are willing to trade off time, as in the time trade-off question, you should be willing to trade off the equal proportion of time, independent of how long your remaining life year is, or remaining life is. And the last one is that individuals should be risk neutral and should not be risk avert nor attracted to risk. If the two first ones holds, the third one could be adjusted for, so it's not as problematic as the other one. But it means, in this context, the last one means that we regard all life years as of equal value to us. So we're not willing to trade off, or so that life years in the future are not of less value to us than the ones we have now. And if you look into the literature, you can see that there are many studies that show that these do not hold. And we don't always work like this. For example, we do assign less value to the life years in the future than the life years we have now. So we are more willing to trade off life years 10 years from now than the one tomorrow. And that means that it doesn't hold, and I think that is something that is very common knowledge in this area. But the QALY model has still been regarded as useful in this context. So it's very important to remember that it is a simplified model, as many models. A very common quotation in this area is that all models are wrong, but some are useful. And I think in this case, there is an agreement among health economists that it is probably wrong and it doesn't fulfill this, but it's still useful. So, if we go back to how QALYs are calculated, in this case it could look like this. We use the same cost as before. Treatment A costs 2.5 million and treatment B costs 2 million. In this case, treatment A also generates 5 QALYs and treatment B generates 4.5 QALY. Then in this case, we would have a cost per QALY, cost per quality-adjusted life years, that would be 1 million per gained quality-adjusted life year. Would you regard this as cost-effective? Or would you regard this as a reasonable relationship between costs and effects? To answer that question, I think you need some help because you're missing the willingness to pay per QALY. And that willingness to pay is usually something that is stated by a governmental agency, a governmental organization that makes decisions. For example, in Sweden we have TLV and we have the National Board of Health and Welfare that make these kind of judgments in their national guidelines and also when they decide about what drugs that should be reimbursed. And if you look at the intervals that are used by the national guidelines today, by the National Board of Health and Welfare, they look like this. So if the cost per QALY is below 100,000 per QALY, it's regarded as low. However, if it increases, and for example, it's between 500,000 and 1 million Swedish crowns per QALY, it's regarded as high. This is not saying that it's cost effective, but it says that whether it's a low, moderate, high, or very high cost per QALY, and this is used in the national guidelines. If you go to the UK instead and look how NICE works with this, they don't have this kind of intervals, but instead they have a willingness to pay per QALY that is between 20,000 and 30,000 British pounds per QALY. So they use this limit to decide whether or not a specific treatment is considered cost effective. However, something that is very important to go back to here is that this is not the only input into healthcare decision making. It is one input as saying something about the relationship between cost and effects, but we have several things that are also considered at the same time. We looked at the human dignity principle before that, for example, talks about equity. And we have the severity of disease, which is something that is also taken into account when doing the national guidelines and when making reimbursement decisions. There has also been a discussion in Sweden about whether or not rarity of disease should have a role in this, if we should be willing to pay more per QALY for diseases that are rare. And in the UK, there's a criterion for end-of-life treatments, for example, where they are willing to pay more for treatments that are at the end of life. And there are many other criteria that are considered when making this kind of decisions. And this cost per QALY is only one of the inputs that are taken into account. So, in conclusion, I hope I'm well in time here. I think some of the most important things to remember are that quality-adjusted life years are a composite measure of effect on health-related quality of life and survival. To calculate QALYs, you multiply the health-related quality of life with the number of life years in that health state. And to simplify it, you can think of one quality-adjusted life years as 1 year with full health. But as you know, it can also mean 2 years with 50% health. There are several methods to estimate health state values, and these methods can generate different results. However, it's not that strange because for example, the questionnaires that we use, they include different kind of questions. And quality of life is something very subjective, and if you use different questions, they will be differently sensitive in different disease areas. So it's very important to look at if the questions that are included in the questionnaires are actually valid for the patient population they are used on. So some of them work very well in some disease areas, while others might be better in others. but they are always, if they are used in quality calculations, it's important to remember that there is always some kind of valuation by patients or by the general public that have done some kind of valuation in the health states if they're going to be used in this way. Quality-adjusted life years are a simplified model indicating the benefit of healthcare interventions. It is simplified, but so far it has been seen as the best alternative. There are many studies going on how to improve the measurement of quality of life, and there are different alternatives for how to get these kind of values that are being presented. But to now it has been regarded as the best way of making or actually illustrating the relationship between cost and effects. But once again, it's only one of several inputs to healthcare decisions, and I don't think anyone sees it as it should be the only one, not at least with the health economists I've been talking to, and not the way it is used by the governmental agencies today. So, thank you very much.
Basics. And I think that the distinctions you made between the different types of analysis, cost benefit, cost effectiveness, and so on, are very important to keep in mind. I was interested in the classifications that you alluded to, 50%, 25% of full health, and how you do that. And I just want to ask you to comment on Pliskin's criteria, because it seems to me that in many cases they are not fulfilled, and you alluded yourself to the fact that there are big variations in people's preferences. I mean, additional years of equal value, that's one of his criteria, and that people must have very different views about that. What's your thought about that?
Well, as you said, there are many studies that have shown that they are not fulfilled, and that, for example, there is some health states have something that is called the maximum endurable time, which means that people don't want to live in those health states more than a certain number of years. Sorry, and after that, they trade off those years in these kind of exercises, and that it depends. The time perspective you use in these kind of questions affects the willingness to trade off years, because the years in the future are not as much of value to us. So I think that it is true, but the question is, how big of a problem is it? Then
$10 today, then 20 on Friday.
Yeah,
right.
Exactly.
We have 15 minutes for questions, comments, and suggestions. Anyone who wants to raise a question or make a comment, please go ahead. You'll use the microphone, because otherwise you will not be recorded.
Hello, I'm Patrik Nylander from the Public Health Agency of Sweden. Thank you for the very informative and good overview of the basics. Could you just briefly elaborate on the background of the thresholds? Not what they ought to be, that's a bigger question, but the background to what they actually are.
I would say that's a very good question. There are many ways of, as you say, of estimating this kind of threshold for the cost per QALY. How this was developed for the work of the national guidelines, to be honest, I'm not sure how it is. Usually it is that you look at previous decisions, what has been regarded as cost effective before. So it's something that develops during praxis. Others mean that you should use, for example, 3 times the GDP per capita. And there's also, I mean, the basic idea is that you should be able to know the cost per QALY of all treatments in the healthcare sector. And if you take something in, you want to know what the cost per QALY is of the thing you take out. And then the cost per QALY should be lower. But that is very difficult to do. So I can't really say exactly how it was developed at that time.
All right, thanks. Any other questions, comments, suggestions? Kjell, and then Ingemar.
Göran brought up the question about prevention. And can you just clarify, how do you handle prevention of a possible event in 20, 30, 40 years time from now?
That's also a very good question. It doesn't really have to do with quality-adjusted life years, but with health economic evaluations. Because when you compare two different interventions, and those are preventative interventions, you take into account the probability of someone getting sick too. So you usually model that in a decision model, where you start with the population that you have today, which can be perfectly have full health today, for example, but there is a risk that they will get sick in the future, and then you have a probability of them getting sick. And what the intervention can do is to reduce the probability of them getting sick. So you use the quality-adjusted life years, you calculate them by taking into account the probability of them getting sick, what the health-related quality of life would be then, what it is now for many years, how it will affect the people that get sick, and how the people that don't get sick, how their quality of life would look like. But so you use a kind of a probability, because what the intervention would do in this case is to decrease the probability of people getting sick. I don't know if I'm very clear on this, but so we still measure the quality-adjusted life years in the same way, but we weight them by a probability of people getting sick.
Emelie, if I may misuse my position here, I want to hang on to Kjell's question, and then Ingmar will get the floor. I mean, one of the problems with prevention is the causal relationship. How do you decide, because you use the phrase life years gained by the intervention, how do you decide the effect of a preventive measure? I mean, anti-smoking campaign, fairly clear, but in many other cases there are so many confounding factors. The cleanliness of the water, the air, the stress at the work, and hundreds of other things. So that is it's not easy to estimate the probabilities here, because there are so many other things also having an impact on the life years that you gain.
No, I agree. And the health economic evaluation would, of course, not be better than the clinical evidence that you put into it. So it's very important that you have used clinical data that you trust when you do this. But I think it's more of a question about the quality of the clinical data than for the economic evaluation. But of course, you need to have probabilities you believe in. But then we also have different methods to handle uncertainty in health economic evaluations, where we do sensitivity analysis and test different scenarios, and to see if we don't believe in this measure, or we use the best estimate, the best probability where we can think of based on clinical data. And if this would be a bit different, what would happen with the analysis then? So what would happen with the results then?
How many ifs here?
Yeah, exactly.
Right. Ingmar.
I'm Göran Hermeréns from SMER. Thank you, Emelie, for a nice introduction to these complicated questions. It's about mathematical exercises, but also these are value-laden, as you said. And I would to hang on a little bit to the question of a QALY, that 1 year with full health could be equated with 10 years with 10% health, or to put it even further, with 50 years of 2% health. It's a bit difficult to really think what 2% health would mean in practice. But I would assume that very few people would like to live 50 years with 2% health, and that could be equated with 1 year of full health. So what are the theoretical assumptions between or behind this mathematical axiom? Is it empirical facts behind it that people really think this way, or is it just to make a mathematical model working at all?
Well, when I say 10% health in this case, you can think about it as if you have this kind of time trade-off question that I showed you before. If I would say that you can choose between living 10 years in your current health state or 1 year in full health, and you would think those two alternatives are equal. So you would be willing to trade off 9 years of full health to not live in your current health state. That would mean that you would have a health-related quality of life weight of 0.1. And that would be what I refer to in this case as 10% on this scale. And there are people reporting that they have that kind of quality of life, that they want to trade off those 9 years they have to actually get improved health for a shorter time, for only 1 year in this case. Some of these values that are used in these or it's very common actually, that they are based on hypothetical values where the general public have valued the health states. And then they describe, then someone describes a health state to them and asks them, would you prefer living in this health state for 10 years or only 1 year in full health? And those values are usually lower than the ones stated by the people that have the disease, which it's a little bit, we actually do a lot of research on this at Karolinska, and I have some of my colleagues here that are working with this too, because you have to think about what kind of perspective you want to use when you value these health states. And if patients usually value their health states as higher, what does that mean? That they don't think it is as bad as being in these health states as someone who just got it described to them think it is? Is it because they have adapted to the health state? And should that be taken into account when making these kind of decisions? So there are many things to think about when you do that. And in Sweden, it has, for example, TLV, the reimbursement agency, argues that we should use the values of patients living in those health states.
But you would need a lot of empirical research to back up these claims,
Exactly.
wouldn't you? Yeah. All right, further comments, questions? Nils Erik?
I'm just curious. There is a lot of international research done by psychologists on the standard gamble, so we know a lot about it. But that's not the problem, is it? Because then you are working within one and the same agent. You are looking, for example, at me and my standard gambles, and they can be used in order to make predictions about what I want to do in the future. For you, the big problem is interpersonal comparisons. And so you can go on doing standard gambles with all the Swedes as many times as you like, and you might not be able to do interpersonal comparisons. And that's the really difficult problem here, isn't it?
No, I agree that it's different if you use them individually for a patient to understand how they think about their own health, and if you use it on a group level. The thing here with making people trade off years in this way is that is the way that you want to make them to be on a cardinal scale, so that you actually can compare them. But it is a difficult methodological problem. But I think, I don't really know what to say there, because I agree with you that it can be problematic, but at the same time, using, there are many issues here. Do people regard full health to be the same thing? Is full health to me the same thing as full health is to you? But I still think it can be used in this way if you use these kind of methods.
But the problem is, isn't it, that if you look at an individual, you get a cardinal scale, I agree with you, but you only get an interval scale. That's not enough to do interpersonal comparisons. Mathematically, it doesn't work. What you need is to get it on a ratio scale, and you don't get that with the standard gambles. You have to make extra value assumptions that, for example, Ingmar, Göran and I, we have some common thing that we all dislike or like as much as the other person. And assumptions like that are not easy to make, so you can't really do the tricks that you want to do. You can do them, but they aren't as easy as it looks.
But why would you say that they are on an interval scale? This discussion is usually held with a visual analog scale, for example, that is used to be an interval scale. is said to be an interval scale because you don't trade off anything. But in the time trade-off method and the standard gamble, you are trading off something, and then it is regarded as a cardinal scale in this context.
It's the case that some of the formulas you used suggest division, and that means that you need a ratio scale.
Exactly, and that's why you trade off why you ask people to trade off life years, or why you ask them to trade off or to accept, you use probabilities so they accept a higher or lower risk. Because that means if you're trading off something, it becomes a cardinal scale or a ratio. You can use it to divide this. But it's, as I said, it is a simplified model and it doesn't work perfectly, but the difference between using a visual analog scale where someone is just stating their health on a scale between 0 and 100 is that they are not trading off something, and then it's on an interval scale, and you can't do this kind of interpersonal comparisons. But if you ask people to actually trade off something, then the scale, the idea is that each step on the scale is worth the same. It's worth the same actually. So that is the point with using these kind of methods to convert it to a cardinal scale.
We may come back to that. I think we should give Emelie a big hand for her talk and her...
Thank you.